Okay, good evening, everyone. We're going to continue second session of OSCE for aortic pathology. Last time we discussed two cases, one is a standard EVAR and one standard open. Today, hopefully, we're going to dig more into more advanced pathology. So let's start first with this case with Dr. Mustafa Abbas. Go ahead, Mustafa.
78 years old man presented to the emergency department hypotensive with abdominal pain and is found to have a large triple-layer duplex. They immediately called vascular surgeon and asked for your assistance.
Okay. So the first question I ask you exactly what would you do? So they call you in emergency room, patient hypertensive abdominal pain, right? Who has a large AAA on duplex, did start to base contrast and has aneurysm. So what do you do first?
Yeah, I will go quickly to assess the patient, take a quick history from him, predisposing factor, hypertensive, diabetic, or any history of aneurysm, past medical history of connective tissue disease or medical history, family history, smoking, drug abuse. Then I will examine the patient, the conscious level, vital signs, and proceed for.
Okay, let's say. So this is what you do first. Let's see what the next thing. So he tell you, so he asked this question. He said the pain started acutely 1 hour prior to his arrival and ready to his back. He has no other medical problems. He is uncomfortable, but maintaining well. He has a tender palpable subabdominal mass, palpable pedal pulses, tachycardic, and his blood pressure is 100/70. So what do you do next?
Okay, it looks partially stable. I'll proceed to investigate him. After insertion of two big cannulae and prepare blood cross-matching, proceed for CT. CT angio.
That's good thing. Because he's stable, correct? That's the reason why you go with that. Okay. Okay, CT scan demonstrate an 8 centimeter infrarenal aortic aneurysm with container rupture into the peritoneum. The neck is about 20 millimeter in length without angulation. Neck diameter 25, and they are healthy, non-disease, iliac disease. The physician taking care of him want to start transfusing him. You should read this one. Because his systolic blood pressure has dropped to 90. He has rupture, and he has a rupture. Do you agree with the management?
No. Once the patient is maintain his consciousness and permissive hypotension is it's good for the patient to maintain him from the free rupture. So I'm not agree for transfusion now.
Not to prevent from really free rupture, but you don't want him to bleed more, because when you read the pressure, he already has up pressure and bleeding. So if you increase blood pressure, he's going to bleed more. So it's mainly to prevent further bleeding, you know. So called permissive hypotensive, which is acceptable. Okay. When you decide it is acceptable, to what level, what blood pressure is acceptable? Like what level I say, no, I need to give him fluid now.
If it's drop less than 70, or there is deterioration in the level of consciousness.
Yeah, correct. The most important level of consciousness, because maybe the blood pressure is not correct, controlled. As far as the patient is talking to you, you know, that means his pressure above 60 for sure. Because I want to drop less than 60, then he become, you know, drop his consciousness level. So as far as he's awake, alert, talking to you, that means, you know, blood pressure is above 60. So I think he's kind of stable. All right, let's go next. Okay, so they cancel transfusion based on the clinical history and objective finding. What would you do next?
I'll proceed for endo. EVAR.
Why is endo? Why endo?
Because it's less morbid and better than the open repair in
Do
rupture.
we have any data?
According to improved trial, I think.
Approved trial. Okay. So, okay, that's acceptable. But why you decide an endo? You said because less mortality. Okay. What else?
The parameters from the CT scans going accepted for the endo has acceptable now.
Right. Because if I tell you the neck is 4 millimeter,
Yeah.
you know, or severe angulation like 90, would you still go with endo? If you gave the same scenario and said the neck is 5 millimeter in length and with 60-degree angulation.
No, we'll proceed for we'll go for open.
Yeah, because see, it's not like a place, unless if you have work in very high standards, you know, because this one's more complicated. You have to go to fenestrated, you know, and in rupture don't have a time like for that, you know. So when it becomes complicated, you know, then this one is better because don't have a time. Then it's better to go with an open repair. If it's like you have all the criteria for straight endovascular, of course, endovascular is better, you know.
Yeah.
This is what the guideline said. The guideline said if it's fit for endo, then you take him for endo. You know, if it's not fit for endo, then it's better to go and start with an open than go a complex aortic surgery in patient with rupture aneurysm. Okay.
Okay.
All right. Let's see next. So you are in the OR right before you start. The patient became hypotensive and his mental status worsened. Describe how would you approach that? So you put him to the OR. They just put him in the OR. They didn't even start any seizure. He's still awake. You know? So become hypotensive and mental status worsen. So what do you do next?
I'll try to catch him by putting a balloon, aortic balloon.
Okay. Describe how would you do that?
I will drape the femoral and access femoral access via ultrasound guided. Then I will insert a wire over computer till above the distal thoracic. Then I will insert a big sheath, actually above 12 or 16, according to the balloon size. Then I will, with good length, 45 or.
What kind of balloon you going to use? What size of balloon?
I will use a Coda balloon or
okay. Coda balloon or Reliant balloon. Okay.
Real, yeah.
What about the balloon come from gold? Called the tri balloon. Can you use it?
No, still there is guttering.
Why?
There is guttering between the balloon. So
you can. So you got a Coda or Reliant balloon. Okay.
Yeah.
What the size of the balloon? 12, 14, 16, 18, 20.
14 to 16, acceptable. Up
Do
to 18.
Do they come with different size?
Coda balloon, I think it's a single size.
What about Reliant balloon? You see, in this way, I can't tell if you use it or not. See, there's a question. The examiner, he can tell if really did it before or not. You see, as I'm saying, always, if you think you didn't do it, you have to be careful. But anyway, so what size? Because I'm sure he'll ask you, because he want to know did he really use it or not before?
I
12,
think
16, 18.
14, 14 or 16.
Okay. You see, look, in the exam, okay, I'm not saying what French, I'm saying the size of the balloon. Be careful. I didn't ask about the size of the French balloon. I say what the size of the balloon. So it's different from the French size, you see. I didn't tell you what French size of the balloon. I said what the size of the balloon. So it's different, correct?
The balloon itself. Okay.
Yes, I'm saying what the size of the balloon. I'm not saying what the French. You know, like when you get any balloon, you know, like 5 French, but the balloon could be 10 by 12 or, you know, 14 by 39, correct? So I tell you what the size of the balloon, not the French size. So does they come with different size?
Yes.
Different, they come. What the kind of size balloon?
Go up to 22. 20s.
Okay. In the exam, because again, here to learn, right? The reason we're running this practice. In the exam, don't guess. Either you know or you don't know. If you don't know, it's okay. Say, I don't know. It's normal. It's okay. It's better than you came up with a size, because I can very easily know that you don't know this, you know, or you don't know the size. Whoever I examine doesn't know size. So it's okay. Say, I don't know. So usually, you know, it is, listen, it's a compliant or non-compliant balloon. And what's the difference? You know what's the difference between compliant and non-compliant balloon?
Yes, this is compliant balloon.
It's compliant balloon.
Yeah.
So compliant balloons, they have no size because a compliant balloon, right? So what does that mean? The more you put inside, that goes larger. So there's no size. Because non-compliant, they have a size. Because non-compliant, whatever you put them, that's it. There's a size, they stop. Like 10, 12, 14. Like if you put in a 10 and inflate more, they're going to rupture. It can't go to 12 or 13 or 14, correct?
Yes.
But compliant balloon doesn't matter. The more you put, the more it go bigger. You can go 10, 12, 14, 20, 24, 46. The more you put inside, you get more inflation. So compliant balloons, they have no sizes. They have a size of the French, yes, 12 or 14 in French, but the catheter, but not the balloon itself. All right?
Okay. Right.
So if you ask you, they come only in one size. We don't have, when you ask for coda balloon or air balloon, nobody asks you what the size. You know, they just, you know, you may ask, okay, what the sheath, because you want to put a sheath, hey, what the sheath size? But you never ask for the balloon size because it's compliant balloon. And compliant balloons, they don't have no size. The reason why they have like a sheath tell you, like if you put 10 cc or 20 cc, it become like 32. If you want like, you know, but like 30 cc become like 46 or 42. So they have a sheet tell you how much the balloon become when you put more fluid. Okay.
Yeah.
But there's no size for the balloon, only one size. Okay. So let's describe how you do the procedure. So in the OR, you said you insert the wire and then you ask for like coda balloon and you insert. So the question, where do you place it?
Supraciliac or suprarenal.
Okay. But how do you know they're going to do an angiogram, or how you don't know that?
For safety, I will go to the distal aorta. So the distal thoracic aorta, supraciliac.
Yeah, but I'm saying, what your landmark? I mean, you're in the OR, you're imaging. How do you know where the distal aorta, or you know where the celiac, where SMA?
Just I will go through the vertebra, I count, then I will put it in heat.
Correct. So you look at the vertebra. Usually, like L2 below is the renal. So you maybe put between L1, L2. You know, because this is where it can become above the renal, even though it could be higher and lower. But this is roughly the area. You know, because if you put it too high, then you still get bleeding from SMA and celiac. You're still losing blood. So the best way to put it suprarenal. But again, if you cannot tell exactly, or you're confused, or you are rushed, you can just put it in the thoracic part in the distal aorta, supraceliac. But usually, the best way to put it suprarenal. Okay, so tell me. So you put the balloon. What do you do next? How much you inflate? How much you inflate the balloon? Because you see, this is the OSCE exam. As I said before, it's not I'm examining your knowledge. I'm trying to see your practical. So it's a question you can get in the exam, you know. So how much you put inside? How many cc?
Up to 25 cc, all to take the shape of the aorta.
Yes, I mean it takes the shape of the aorta. This is, but the question is that you don't blind. There's no angiogram. So how do you know the shape of the aorta?
I can use a contrast to fill the balloon.
Yeah, but how do you know you are how the size of aorta? You continue, and then how do you know the size? You can rupture the aorta. You see these practical questions? It's an important question. What you do, as it said, you measure the aorta in the CAT scan, right? So you know what your supraceliac aorta, or it depends where it is. So you measure size of the aorta in the CAT scan because you did a CAT scan. The size of the aorta, you know, it's like aorta is like 30 or 24 or 26, depending on size of aorta. And then you have the balloon come with the sheath. It tell you how much you put inside to get that size. So you look at the sheath and tell you like to get like to 30, you have to put like 15 cc. So you go with this, you know, this is the safest way. I mean, the other way you can go blindly, just as you say, you see like when the balloon become like straight instead of, you know, circle, but this is not very accurate, you know. The best way to go is a measurement, you know.
How can I measure it again?
Sorry?
Can you mention it again how to measure it?
Okay, the balloon, every balloon comes with a sheath with the balloon. Inside the balloon, if you open it, like when you open any balloon, there is always like a table. Tell you like if you inflate pressure to this number of fluid, you get this pressure. This is the size of the balloon, you know. So every balloon, for the balloon or Reliant balloon, if you open it, you see a paper inside with a table. Tell you if you put 10 cc, the balloon will be size will be like 30. If you put like 25, become like 35 or 36. You see? I don't remember. You don't have to remember a number. I don't remember the numbers. But you look at the sheath, and you already you know what the size of your aorta because you size it on the CAT scan, and then on this one you can look at the sheath and say, okay, my aorta size on the CT scan is like 30. You look at the sheet, tell you have to put like 20 cc to get to 30, so you put only 20 cc. You understand?
Yes. Okay. Thank you.
So that's the way you tell. But before that, when you insert it, you put a sheath, right? Before you insert the balloon.
Yeah.
Okay, what type of sheath you put inside?
Long sheath, 45.
Why long sheath? Why you want a long sheath?
To support the balloon from the pulsatile aorta.
Correct. Because aorta balloon can go down, you know? Because what happened is that when you measure the aorta, patient may be hypotensive. So you measure it like 30, but maybe after you resuscitate the patient, the aorta get dilated and balloon kind goes down and you bleed again. You understand?
Yeah.
Because CAT scan usually done when patient hypotensive. So you always you are underestimating size of the aorta. So when you measure it, it was size, but the moment you put the balloon and you get, then you stop, give patient some time for the anesthesia to catch up, right? So by catch up, they give more fluid, more volume. Now the aorta get dilated, then balloon goes down. So always you have to put a long sheath to support the balloon and prevent from coming down, okay?
Yeah.
All right. So, okay, so you put the balloon, inflate it, you put a long sheath, inflate it, you know. You see, don't also give too much information, just say long sheath. If you ask you what length, you know, it depends how long you want to go. You can go like, you know, 25, 40, usually it's like 45 to 60, depending how you want to put it. But don't give numbers. Anyone, unless if he asks you, say, okay, I put a long sheet to just support the aorta. Okay? All right, so you did that. What do you do next?
Then you proceed for surgery.
Yeah, but I want to know the steps. What are the steps? Let me see if the question, next question, what? Why is not working? Just a second. No, they already gave you. So yeah, so how you do? So approach, so you put the balloon, what do you do next? Describe the procedure. Because this is an OSCE, so I want to, as I said, an OSCE exam will ask you about procedure, how you do the details. So how you do it? Did you do it before? Fracture aneurysm? Hello, Max. Can you, yeah, I can hear you. Go ahead, Mustafa. So what the steps? So you did balloon. What do you do next? You're going to do EVAR, correct?
Do you
So
hear
how are
me,
you going
boss?
to do an EVAR? No, not now. I hear you. Can you talk?
Yeah. Yes.
Okay. Yeah, go ahead. Now it's better.
We'll go for EVAR.
Okay, so tell me what the steps. Let's say the balloon, you went from the right side. Okay, you put the balloon. Okay, so what next now? So you put the balloon, you stop, you give some time for the anesthesia catch up. So anesthesia tell you, okay, blood pressure now is fine. Blood pressure is like 100 over 70 now. Patient is stable. Please proceed. So we're going to do next. Hello? I think I have a problem with Mustafa. Hello? I think I lost him. Anybody want to volunteer to talk about the procedure?
Okay, I will try to continue.
Okay. You are Abdulrahman?
Yes.
Okay, go ahead. So again, he said he put the balloon. So what do you do next?
Okay, I will use a balloon contralateral. If I use main body to the right, I will put the balloon left side. Then
Whatever you want.
Hmm?
So tell me when's the balloon. Let's go step by step. So balloon, you went through the right or left? Whatever you want. Just tell me what you want to do.
According to the size of the vessel, less tortuous and large caliber, I use main body. That side, I will use if I write.
Look, Abdulrahman, this is going to confuse the examiner. I don't go right or I don't care. You tell me I go to right, then I go left. So don't tell me if I go right, I go left, right. No, that's not good in the exam. Again, in the exam, I'm not asking you how they do the procedure. I'm asking you how you do it. And I want how you do it by yourself. So tell me, I go from the right, I put balloon, or I go from the left, go balloon, but don't tell me if I go from right to left or left to right. So pick up one position and go from there.
Okay, I will go main body to the right side and balloon to
Just
the
second.
left side.
Okay, so the balloon on the, but you see, this is very, I want in details. So you put the balloon on the left side, correct?
Yes.
Okay, what next step? I want steps because this is an OSCE exam. I want to step exactly how the wire, how you change it, how you cannulate, everything step like in the OR. So after you put it, the balloon there, patient is stable. What next step?
I will cut down to the right side. Mustafa Raka?
You cut down on the right side. It's okay.
Okay, Mustafa come back.
Mustafa, you went back?
Yes, boss.
You want to continue? Go ahead.
Yeah. Okay.
So you put the balloon on the right or left? Whatever.
Proceed
Just
from
choose one.
Right or left. I will proceed from the left side, the balloon, then the main body from the right side.
Okay. Tell me the procedure except in details. So what you do? How you put the main body?
Okay. Firstly, I will insert the big tail, then take a first run up.
You insert the big tail from right or left?
From the right, then I will take a measurement first, then I will take it out. I will insert the main body.
Just a second. As I'm saying, in the exam, you get yourself to trouble. Okay, this is the way I say, okay, stop. You said I do measurement. Now tell me what measurement you're going to do.
Just to identify the renal, lower.
Okay, so that's not a measurement, correct? This is identifying the renal. So you label the renal. You don't do any measurement. Measurement already done on CAT scan. We don't do measurement in the OR on the angiogram. Unless a patient is unstable and you didn't do CAT scan and you want to see if it's suitable and like sometimes patient unstable. So you rush him to the OR. You have no time to go for CT scan. So you rush to the OR, you put intra-aortic balloon, and then yes, you put a big tail, you do an angiogram to do a measurement to see if he fit for endo or not, you see? But if he's already stable and already came to the OR with a CAT scan, I don't need to do any more measurement. I just want to see where the renal, okay?
Yeah.
So it's different scenarios. It depends what scenario he gave you. If he gave you a scenario that he is not stable to go for CT, then he said, okay, I'll go to the OR, I'll go for contralateral limb, I put balloons, And then from the other side, I go put a pigtail, do an angiogram, then I look at the neck, the length, the width, and then all the aneurysm and the iliac and everything, and I do my measure. Of course, he may ask you, okay, but if there's any clot in the neck, you may not see an angiogram, but it's okay. It's an emergency, even if it's a clot there, will be like a couple of millimeters. So I don't think big major. You're going to oversize anyway, so I don't think be a major difference. Because in emergency, you want to get patient out of the table alive. It's not the time to do a perfect procedure. Even if you get something in the future, you can always fix it. So in this case, it's no CAT scan. You do the big do an angiogram. You do your measurement, and you pick up your device. If it's already, you mention the renal. So okay, so you did that, and you identified the renals. You took the pigtail out, and then what you do next?
Insert the main body. Okay, and deploy it.
You inserted the main body. Okay.
And deploy the main body till the down.
Okay. And then we're going to do now.
Then we'll try to insert another balloon via the same side.
Just a second. So you deploy this second. You said you deployed from ipsilateral until you get the contralateral limb out, and then you stop. Correct?
Yeah.
Okay. So now you're going to get to cardiac contralateral limb. How do can you? You said you put a second balloon. How are you going to put a second balloon?
From the ipsilateral within the graft.
But ipsilateral, you did not deploy it yet. You said I will not deploy. You stop. You said.
No, I will deploy it. I'll deploy it.
See,
fully
completely.
Deployed.
It's different. You see, in the selective you stop, but in emergency you don't stop. You can deploy it all the way because you need an axis. You see, so you need an axis from here. So you deploy it completely. You remove the sheath and you put, of course, you move the main body, and you put a sheath, and then you go with you said with the second balloon. Why need a second balloon? You already have a balloon.
I want to deflate the first one, and insert the contralateral. Difficult to insert it with that with the balloon in the contralateral.
So it's difficult to insert it with the contralateral balloon. What do you mean?
There is a balloon already in the contralateral sheath.
Okay, correct.
So we need to remove it, and still there is a gate open. So difficult to need to remove.
Correct. So you put the second balloon. Where do you put this balloon? The second balloon. Where do you put it?
Within the graft.
Inside the main body of the graft. Okay.
Yeah.
And then you inflate it.
Other option, there is another. We can put another balloon from the brachial by the 7 sheath.
Wow, you see, now you are doing well until you get yourself to trouble. Now you get yourself to trouble. Now I'm going to ask you how you do this one, because how you do it from brachial.
I think there is a new modality, 6 French called the balloon.
Okay, so okay, I'm with you. Go ahead, describe to me how you do it from brachial. So you get there your wire, and then you have a balloon in the suprarenal aorta. So how are you going to get through this area with a balloon inflated there?
Put it above the previous one.
Okay, you put above previous one, and then you deflate the first one, right?
Yeah.
Okay, and then you remove it.
Yeah. Can you let the the contralateral?
Then patient become hypotensive. I mean, have you ever did like supraceliac aorta when you clamp? I mean, SMA, remember, SMA and celiac, they have a lot of collaterals. I mean, renal, you don't get backbreathing from renal because they are end artery, correct? SMA and celiac, they're not end arteries. There are a lot of collaterals, right? Sometimes you see SMA and celiac are occluded, and this still patient has normal bowel circulation. So you can get a lot of back bleeding from celiac SMA down to the aorta, which is open to the bowel, to the arterioperitoneal, and then you can get a lot of bleeding again. So I don't think it's a good idea. Maybe somebody describe it, but it's not a good idea. Don't volunteer extra information. Why you go with this row? I mean, don't try to impress the examiner in the exam. Try to get past the exam. It's not a time to impress him that you know a lot of approach, a lot of way to do things. Because the time you get yourself to trouble, okay? So I will not do that, okay? The easiest way, as you said, you go from, you're doing very well. You go from ipsilateral, you inflate the balloon, the main body, you deflate the other balloon, you deflate it, you take it out, and then you cannulate the contralateral limb, correct? And then
Yeah.
what after you can after you connect contralateral limb, what happened? What do you do now?
Deploy the other limb, the contralateral.
Okay.
Uh,
And finally,
do the final run.
before the
See,
final run, what you do?
g-
You deflate the balloon, take the balloon out, right? Don't
Yeah.
forget, take the balloon.
Let-
So you deflate the balloon.
Then we will do the final run to see
Okay.
if any endo leak and if any thrombus
Okay.
or any occlusion of the renal.
You see, as I said, don't, please guys, don't volunteer information. That's, I do on completion angiogram. That's, if he tell you what you're looking for, mainly you're looking for type 1 endoleak, not looking for thrombus. I don't care about thrombus. You're looking for in type 1 endoleak. But again, when you answer, try to be precise and to the point. I remove the balloon, the completion angiogram, everything is fine. If you ask, okay, what do you mean? What you're looking for? Then again, don't just stop and let him ask you his question, so you know exactly what he's looking for. Okay. So if you tell him I'm looking for thrombus, they're going to tell you, okay, what type of thrombus? Where is the thrombus you're looking for? What if you find a thrombus? We're going to deal with it. You see, you get yourself to different pathway. He was not planning to take you there. Okay. All right. So the angiogram looks, everything looks fine. Let's see what the next question. What if you cannot cannulate the contralateral? What if you cannot cannulate the contralateral gate? What do you do? Hello? Is Mustafa there?
Yes, boss. Yes, boss.
Okay.
Hello.
So what do you do if you cannot connect contralateral gate? What do you do?
I will snare it from the other side.
Okay. So you go with a vertebral catheter, or you go with like no contralateral catheters, or you go with like rim catheter, try to stay from other way. Okay. Do you go from brachial? Hello? Can you hear me?
Yes, boss.
Yeah. Brachial is not a good option here because you have a balloon, right? We did not inflate the balloon. So the best way to go from ipsilateral limb to over the gate divider, and then you can be snared from below, as you said. Okay. What if none of these maneuver was successful? Then you can throw from brachial, but the problem with the brachial is there is a balloon there. You have to be careful. But you can, if you push it with a vertebral catheter, you can get through it. You are able to see the rupture. Okay. EVAR, get the patient to ICU, and following morning the abdomen becomes tense and he's oligoric despite aggressive regurgitation. What do you think is happening to this patient?
Abdominal compartment syndrome.
Abdominal compartment syndrome. Okay. So how do you measure it? How do you know? How you measure the abdominal compartments? What's the normal pressure for the abdomen first? What's the normal pressure? This I'm expecting he asked this question. What's the normal intra-abdominal pressure?
7 to 5.
How much?
7 to 5.
Usually
7 to
a
5.
small number. Yeah, but usually it's the lower to upper, not upper to lower. So 5 to 7.
5.
Right? Okay, so 5 to 7 minute mercury is your normal pressure. Okay, so to say a patient has abdominal compartment syndrome, what pressure should be more than what?
More than 20.
Okay, so anybody has more than 20, we call it abdominal compartment syndrome.
If he had end organ failure.
Okay,
Oh.
so you have two things. So if he does not have end organ failure, what we call it? This is the pressure is 20, but all organs are working. What we call it?
It's just a compartment or raised intra-abdominal pressure. We need to be observed a minute.
So if the pressure is more than 20, let's say the pressure is 30, and the organ all perfuse, is this abdominal compartment syndrome or not? Yes or no?
20, yes.
No, 30.
30, yeah.
So, but he has no organ malfunction. Everything, kidney is working, heart is working, kidney is working, everything is working.
What about the bowel?
Everything, a bowel is fine. No bowel ischemia, nothing. Everything is perfused well, but the pressure is 30.
It's
It's
increased.
a difficult question. It's a difficult question.
It is elevated
okay.
intra-abdominal, but I think it's.
I mean, do I need to take him to
We'll
surgery?
reassess
Okay,
again.
make it easier.
Maybe there is something missed.
No, we don't miss anything. Do you take him to surgery for decompression or not? Because make a difference, right? It's a pressure 30, but everything is working. Do you take him for laparotomy or not? Decompress the abdomen or not? You see why it's important to know that? Because his surgery is involved.
Okay.
It's tough.
To me, I will go for surgery and open the belly and leave it open with back therapy. Better than to lose the
bowel or something like that. Okay. Anybody has different opinion or everyone agree with that? Let me see.
Prof. I agree. If the patient has no symptoms, yes, Prof.
Go ahead. What are you saying?
If the patient has no symptoms, no intervention. Or signs or because the patient is stable. Just increase intra-abdominal pressure.
Okay. So if the pressure more than 30 without end organ failure, then we don't call it compartment syndrome, right? We call it intra-abdominal hypertension, right?
Yes.
Okay, and this one we have to watch it unless he developed organ failure, then we do it. So to get a compartment syndrome, you have to have both intra-abdominal hypertension plus end organ. If there's no end organ, no, we don't interfere. Okay.
Yes.
Because it's not affecting the abdomen. You know, it's the organ still perfusion. What is the abdominal perfusion pressure? You know what abdominal perfusion pressure?
Yes, this is the main arterial pressure minus the intra-abdominal pressure.
Correct. So what is the normal? Okay, it's very simple. Let's say what is the main arterial pressure for Bani Adam? I mean, for somebody normal, it's around 80, correct?
Yeah.
Normal, but 80. Intra-abdominal pressure should be less than 20, right? To be normal. Should 10, like 10, right? Anything less than 10 is normal, less than 20. So minus 80 minus 20 becomes 60. So anything more than 60, it's normal. When become less than 60, then we say he may have a compartment syndrome. Okay, or intra-abdominal hypertension. So some people they use the pressure, some people they use also the what we call the abdominal perfusion pressure, which is, as you said, the mean arterial pressure minus the intra-abdominal pressures. So when it's less than 60, it's a sign that the intra-abdominal pressure is too high. But most people they don't use that; they just use intra-abdominal pressure and the end organ failure as or compromised flow to end organ failure as a sign of compartment syndrome. There's no end organ failure. We call it intra-abdominal hypertension. Okay. He may ask you what the grading. They have 4 grades. You know what the grading for intra-abdominal pressure? Anybody knows? Because a compartment syndrome is an important, guys, to read about it, because this is an important, we see it, and you have to know when you intervene, when not, you know. So they grade to the 4 grade. The grade 1 when the intra-abdominal pressure between 12. We said the normal is up to 7, right? So when it's between 12 to 15, we call grade 1. 16 to 20, we call grade 2. 21 to 25, grade 3, and more than 25, we call grade 4. So just keep it in your mind, just in case if you really want to go deep and ask about this question. The second question will come, okay, how you measure it? I want to see how you really, if you did it before or not. So how you do it? How you measure the intra-abdominal pressure?
Okay, we'll measure it via the Foley catheter inserted in the bladder. We'll inject about 20 ml within the bladder via the Foley catheter. Then we'll connect the Foley catheter with the arterial line monitor.
Okay, this is one way. It's a simpler way, but it's okay. It's acceptable. But you have to put at least 25 or more cc in the bladder. You connect to the pressure to the, as you said, to the central line back, and then you can measure it. Yes. What other way? What about if you just use a ruler and Foley catheter? Can you do that?
Yes.
How you do that? You know?
Yes, we'll measure it by putting the ruler beside the patient, so the pressure will be counted from intra cystic, not the heart.
Okay, so the way you do it, again, you have to be sure that the bladder has at least 25 cc, because the bladder is empty, it doesn't work. So you have to be sure you have at least 25 cc, or you inject 25 cc in the bladder, okay? And then you get the Foley, you lift up the Foley, and you put a ruler, as you said, in vertical positions, but you have to put the 0, the most important. The 0 has to be a level of what? Anterior suprailiac spine with the mid-axillary line. In this area, you put the 0 of the ruler. And then you lift up the Foley, and you can see how much the fluid going up, and then you can tell the pressure. This is if you don't have a central line back. This is 2 ways to do it, okay? But but compartment syndrome is an important. So how you treat it? Let's say he has, like this patient, he become oliguric. So how you treat this patient?
Just do ciliatomy, okay, and put a dressing.
Okay, but I mean, you have to close the abdomen, right? You can't leave the bowel free. So you open the abdomen, and what you put?
Back dressing.
Okay. Vac dressing. No. We got now, you see. So you open the belly, and you open the fascia, and then the pressure is open, and bowel in front of you. So what you do? You just put a vac dressing. Then the bowel will stuck to the vac.
I will.
You have to close it.
Yeah.
Right. But, so you get a mesh, biological mesh, or you get a back, you know, whatever you, but it's just temporary, you know. I suture to the edge of the fascia all around it. And then if you want to put a vac, I have no problem with a wound vac after that, in case edema and, you know, oozing. But you have to put a mesh there or a back and suture to the okay.
Yeah.
And then you put that. Don't put exactly. Don't put the vac on the bowel. No. And then you couple days, and you take him back couple days whenever he's fine, and then you can close it. Okay.
Close it.
Or sometimes that's the way with the mesh. Sometimes you can't close it because otherwise so stand after a while. So just leave the mesh and you close the muscle. I mean, close the skin, Then he get a ventral hernia, which you can deal with that later on. Okay, because patient is rupture aneurysm, you want him get survive in this situation now. So if you cannot close it, if he said like you cannot close a couple days, then again just leave him alone, and as again, and then you can deal later on with the hernia. In the chat they said you can use a Badera back, which is a good idea, or Bogota. All right, I think we're done with this one, right? What is that? This is how you do the aortic balloon. You see this one?
Okay, I have a question, sir.
Yes.
You see the double balloon. You see it? This is the way as you describe. You put the balloon, you go from contralateral side, you put ipsilateral, you put the second balloon, you deflate the first one, you take it, and then you put connect contralateral limb, deploy it, and the last thing you take the balloon out. Okay? Why this one is here?
Dear Professor, may I ask a question?
Yeah, please.
I'm asking about when the coda balloon is inserted, how can I introduce the stiff wire? Can I proceed it beyond the balloon to the aortic arch and ascending aorta to load the main body of the device?
This is very good questions, that mean you tell you follow up in your practical, yes, usually even with a balloon, because it's a soft balloon, is a compliant balloon. It's not like non-compliant balloon. You can do that. Let's say for some reason you cannot, so you go with a vertebra and with a glide wire. Let's say if you cannot, a lot of resistance, then what happened? I just deflate it for like a couple of seconds, get the balloon wire through it, and then inflate it again. Okay.
Okay, thank you, Professor.
You're welcome. Next, any other questions?
Yes, bro. I have a question.
Yes, please.
Can I put a aortouniiliac?
Yes, if an emergency, yes, but I tell you what the problem is aortouniiliac. It may, this was really is a common and old time, because you need to block the contralateral iliac. Because if you don't block it, you get retrograde perfusion, you can do fem-fem. So you get a reperfusion through the contralateral limb, and then you get bleeding. So if you think about it, it may take same time as bifurcated one. So in reality, yes, you can do aortoiliac and fem-fem, but you need to block the common iliac artery. But in real life, nobody does it these days. In old fashioned, they used to do it, and now they don't. The only time you do it, if you don't have like many sides, you only have one size, or you don't have it in, over the counter, or for some reason, and it's the only one available, then you can do it. But I will not be my first choice for sure.
Sorry, another question. Percutaneous, Ivor.
Yes.
Tubro glide?
Yes, tuber glide.
Okay.
Always better to be able to tuber glide.
Thank you.
Just to be on safer side. Contralateral limb 14, up to 14. Some people, they just do single. Up to 12, 14 would be fine. But anything above 16, you need two. But you may get away with one if up to 14. You can get away with one broke line. Yeah. Any other question? Okay, let's go to the next case. Who's like to do it? Abdurrahman or Georgios or Barra?
No.
Who's available?
Okay. We'll do it, Prof.
Abdurrahman?
Yes, Prof.
Okay, you want to do it? Go ahead.
A 73-year-old woman who is currently heavy smoker presented to the emergency department with abdominal pain, malaise, and fevers for the past 2 weeks. These symptoms started after a recent hospitalization for pneumonia that required IV antibiotics. She is thin in stature and is independent for all activities of daily living. A CT scan was performed that demonstrated an infrarenal circular aneurysm with some wall thickening and pre-aortic fat stranding.
Okay. So the question is, Sorry. What do you do next? So what do you do? So they call you. You are in the clinic, the ER. They call you for these things. So what do you do?
I will take history and physical examination.
Okay.
History, I will ask if she has history of abdominal aorta aneurysm.
Okay.
Or if a family history of abdominal aorta aneurysm.
Okay.
If there is infectious history like brucella.
Yeah, especially brucella, right? Brucella is very common in our area. Salmonella, brucella, but salmonella is more common really. Go ahead. Okay.
And if there is other comorbidities like cardiac, pulmonary.
Okay. And you do physical exam, of course,
Physical
right?
examination. Yes, abdominal examination, local abdominal examination. If there is tenderness, palpable abdominal mass, palpable peripheral pulses.
Okay, that's enough. So she reported an intentional weight loss over the last few months, weeks, and night sweat. Her pain started the day prior and has been worsening. She has no significant family history. Exams show tenderness to deep palpation of her abdomen. What's your working diagnosis? What do you think we are dealing with first? What we are dealing with?
Either inflammatory or infected aortic, inflammatory aortic aneurysm or mycotic aneurysm.
Okay, but you see, why is inflammatory? You see how we get to start now to questions? You see, now I'm going to go to inflammatory aneurysm, what type of inflammatory aneurysm, how they diagnose inflammatory aneurysms. You see, now you get yourself to trouble because you see, now I'm going to tell you, okay, what type of inflammatory aneurysm, what type, talk to me about Takaya, so tell me about, you know, what type of, how you treat them, how you diagnose them, how you differentiate between inflammatory and mycotic aneurysm. So you shift your speaker to all new game. He was not planning to get there. So this one is the most common mycotic aneurysm. She has a fever, you know, and the weight loss, and she has a pain. If you ask her what else could be, so what you're working on most probably is a mycotic, most probably is mycotic aneurysm. As I'm saying, don't volunteer too much. If you ask you what else could be, say, it could be, but because the fever, most probably I will go with mycotic aneurysm. But from beginning, just give him one diagnosis, you know. Again, in the exam, give one diagnosis, one procedure. You can't say it can be done so and so and so. You want to know what you do. Like if I infect aneurysm, you can't say I can do in situ, I can do axillobiofilm, I can do whatever. You know, no. You want you to know what you do, not what could be done. If you ask you, okay, what other possibility, you tell him, okay, so I will do so and so. If you ask you any other way to do it, you say yes, other way, so and so. But don't in the answer, you don't give multiple choice. You give multiple answer. Okay, like when last time you told me go from the right, go from the no, I go from the right, and maybe go from the left. You know, so you try to be specific in the exam. Okay, so mycotic diagnosis. So what's your working diagnosis now? So what do you do now? So most of you are thinking about, you know, mycotic aneurysm. So what do you do next? So she came. She's a fever, weight loss, night sweat. So what do you do next?
Okay, I will do first the inflammatory markers, ESR, CRB, and WBC scan.
Okay.
And also CT angiography.
Okay, so CT angiogram mainly, and you WBC and workup, and you said maybe blood for culture, correct? You know, so because you think she has a maybe, you know, infectious, so you think all this workup. Okay, let's see what next. What workup you want? As you said, you get a CT angiogram, correct? And WBC and ACE and all things. Okay, WBC is 16,000, and her renal function is normal. Blood culture are bending, and her inflammatory markers are both elevated. Her cardiac function is fine. What's your next step? You already answered that. You do CT angiogram, right? So what your, maybe we went too fast. So what's your next inflammatory? They didn't do a CT yet, right? Yeah. Okay. But you did CT angiogram. What if her cardiac function is poor? She went to undergo surgery. So I think what the next step, you want to do what? After CT angiogram, what going to do? Surgery or open or endo? What your treatment will be?
Open surgical treatment.
You prefer surgical treatment. Okay. Why not endovascular?
Because mycotic aneurysm will need to remove infected aortic aneurysm and make debridement.
Okay. So your next step is to do an open repair, correct? And remove it. It's an infected tissue and debridement everything. What are you going to do, in situ or external chemical bypass?
Regarding the organism type, if it is a virulent organism, I will do extra anatomic bypass. If like gram-positive organisms like staph or streptococci, I will do rifampicin soak the graft
In situ.
inside. Yes.
Called in situ. This is, so you looked at the type of the organ to tell you if you go in situ or external chemical bypass, which makes sense. What else you look for to decide?
Okay, cardiac workup. If patient fit for surgery or not.
So you mean the cardiac function, correct?
Cardiac function, yes.
So
Pulmonary.
the cardiac serves. Well, okay, why in pulmonary? Why pulmonary?
Cardiopulmonary disease. I mean cardiopulmonary disease. If severe.
Cardiac. Correct, cardiac. So, okay. But here he said cardiac function is fine, correct?
Okay.
So that means it can fit for inside
surgery.
So let's go back again, summarize for everyone, because you get everyone confused. So to decide inside or external bypass depend on two things: the type of organ. If the type is organ is virulent, like in a gram-negative, like Candida, Pseudomonas, MRSA, maybe it's better to do external bypass, right? Whereas like strepto or staph or even salmonella is sometimes not very, it's no pass. You can do in situ, correct? This is well, the second thing is the cardiac function. If the cardiac function is good, then you prefer to do in situ. If the cardiac function is bad, you do axillobiafilm, right? So my question, why the cardiac function affect your decision regarding in situ or external bypass? How is it going to affect? Why, if it's the heart is bad, you do axillobiafilm? Why is the heart is good, you do in situ?
If cardiac function is poor and I do major operation, I may lose the patient on the table. So
why was it different? Because in both you're clamping the aorta, correct? So what's different? Because if you do external bypass, you can to clamp the aorta and switch out the stump. The other one, you clamp the aorta and you do aorta by FEM. So you both situation, you're clamping the aorta. So how is it make it different if it's cardiac to change your approach if patient has a good or bad heart?
Okay, because if I do axillobifemoral bypass, I do first the axillobifemoral bypass, then I will come to clamp aorta, which reduce mean arterial pressure. If I do without axillobifemoral bypass, mean arterial pressure will increase and ejection fraction will decrease. This will affect the heart.
Okay, it's very good. So if you have an axillobifemoral first, then this will be to compress the heart. So when you clamp, will be not much pressure in front of the heart because the blood can go through the axillofem down to the legs, correct? As you said. You don't see major change in the cardiac output during clamp. So it's a good size. Like the same, when you do like aorta bifem for aortic occlusion versus aorta bifem for aneurysm, is different. When you do aorta bifem for occlusion, you don't see much hemodynamic changes because aorta is already occluded and patient already has collaterals. So when you clamp the aorta, you don't see much stress on the heart. But when you do aorta bifem after aneurysm resection, then when you clamp the aorta, you put a lot of pressure on the heart and you make it with a heart problem. So it's two different things, the same things here. Okay, What if her cardiac function is poor? We said hydroxyl by FEM. She agreed to undergo the surgery. What special consideration do you have when performing this procedure? What are you looking for? You mentioned that before, the type of organism, right? If it's like, if it's like staph, or because this affect your decision, correct?
Okay.
What type of organism matters? You just mentioned it, right? Staph, strepto, or gram-negative. So we did that. Let's keep going. Microbiology results show the patient has streptopneumonia. Describe your operation. So she has a strepto. Which is, this is high or low virulence? This one.
Strepto, low virulence.
Low. Okay. So you're planning to do what? In situ or extranatomical bypass?
In situ.
Okay. So describe your procedure. How you do, how you. But go not much detail, but not the important details. Not like I prep with ibetadine, everything's midline incision, all midline the things. Incision. Yeah.
Okay, midline incision.
Okay.
Then exposure to aorta and clamp distal aorta bifurcation common iliac from fast. Then
no. This is too fast. No. This is too fast. And this is where we need more details. You open the aorta. I want to see where you put the valve. Okay, I want to know if you did it. Where you put the valve, how you open it peritoneal, what you see in front. So you need more details in this situation.
Okay, midline abdominal aorta, midline incision. Then after opening the falciform ligament, then I will take a small transverse colon and transverse colon and omentum to the cephalic, and small bowel to the right of the patient. And ligamentum trace, I will start open to the ligamentum trace, just lateral to the duodenum. I will open anterior to the anterior and right side of the aorta to avoid the injury of inferior mesenteric and sympathetic plaques. Then after a good dissection, then I will clamp fast bilateral common iliac. Then I will clamp if it is good neck, infrarenal aorta. If it's not good neck, I will mobilize the renal vein. I will try to clamp suprarenal aorta. Then I will open the.
Okay, that's enough. But just for time saving. Okay, so you know the procedure, but you have to go in detail in the exam. That's good.
Okay.
So what type of conduit are you going to use?
Rifampicin soaked endocrine graft.
Okay, acceptable. Okay, that's good. Is any other conduit you may use?
Cryopreserved allograft. Or
okay.
Vein new superficial femoral vein or femoral vein.
Okay, femoral vein. Okay. All right. I mean, it's acceptable. What else?
Homograft bovine pericardium.
Yeah, well, pericardium. Okay. Okay, this is a good answers. I think it's acceptable in the exam, but in real life now, most people they don't use rifampicin anymore. They don't like NICE procedure. It's very morbid, unless you are like very aggressive, like maybe gram-negative, then you put the vein. So most people now they use the bovine patch, and they make like a tube and put it inside too. But again, I mean, whatever you answer is okay. I mean, I have no problem because any of options, because maybe you may don't have a bovine, you have a rifampicin, sucked graft is acceptable, no problem. He may ask you how much it's important to read how you suck it, how much you put rifampicin, how long you keep it inside. So you need to read about it. He may ask you about this question, okay? Because you want to be sure that you know how to do it.
May I check? It is like 600 gram, 2 ampoule of 300 milligram fial. Isn't it? I will add 10 to 20 ml of saline.
Okay. And how long you suck it for?
15 to 30 minutes.
Yeah, 20 to 30 minutes. Correct. Yeah. That's good. So let me ask you these questions. All right. All right. Let's see next. And then what after? Yeah. What you finish after you put that? What you do? So you put the graft, and then what you do?
Extensive debridement of all defaculated tissue.
Okay.
And
This is for culture, of course.
for culture, yes, for culture, and I will irrigate the abdomen with antibiotic.
Okay.
Then can I put the drain if I fear to?
You see, don't say I can. Say you want to put or not.
I got.
You put, yes. Where you put the drain?
Inside the retroperitoneum.
Inside the where? Where?
Retroperitoneum.
Peritoneum. Okay. Like just you like behind the colon?
Yes. Okay. I didn't hear.
I mean, I will put it inside the sac really if you want me. I'll put it inside the sac because like it's an abscess, right? So you put inside the abscess. The abscess is in the sac. So if with me, I mean, it's okay with me to put there, but I don't think it's going to help much. Peritoneal will not be helpful. Unless if you mean by peritoneal, you put it inside the sac, then yes, it's acceptable. All right, so you put it there and you close. What else you have to do? Something very important you forgot.
Continuation of antibiotic up to 6 weeks.
No, before you send the OR, what do you do? It's an infected aneurysm.
I will take the select tissue or debridement tissue for culture.
Yeah, you did that. What else? With Omentum, right? Omentum.
Yes,
Don't forget Omentum.
Omentum, yes.
Yes,
Okay.
this is the only difference between normal surgery and this one. So it's different from normal EVAR. I mean, open repair, the same steps. The only thing that cannot be different, and you have to take a culture, debride it as much as you can, and do it Omentum. You know, and of course, what as I said,
or tissue.
Yeah, of course, Omentum better. No, tissue is not a good idea. Where is you get tissue from? What do you mean by tissue? See, there's no tissue there. I mean, relax, the opposite. You have to take the most of the sac out because all infected. So you debride it, you take most of the sac out, you know, because you see, it's different from, see, this is a good way you mentioned that. You see, in normal EVAR, we get the sac, we close it above the conduit. Here, no. Because if you close it above the conduit, it may form an abscess, again, infection. So you don't close an abscess. So we debride, we take the most of the sac out. Then we get the Omentum to wrap it around and to protect it from the duodenum and for infection also, because Omentum has a lot of blood flow. Okay?
Okay.
So this is very important to do that. All right, so you did that. Let's see what the next question is. There's none of this graft at your institution. So there's no graft. You see, trinorphan be seen, no bovine. So what do you do?
Extraanatomical bypass.
Extraanatomical bypass. All right, but you should maybe decide that before you start because you have to do it not during the procedure, right?
Yes.
Okay, what else you can? But you decide to do in situ. What else other you can do?
Silver dagron.
There's no stuff. There's no graph. There's no graph. You have no graph.
Vein. I used superficial femoral
right? Yes. What do you call this vein? What do you call this procedure?
New aortic system.
Yeah, it's procedure, right? All right. So I'm going to tell you how to do it. So describe to me how you do it.
I will take two. I will talk.
Procedure. Procedure. Okay. All right. So you do how you do the vein? Describe that.
I will take bilateral superficial femoral vein, and I will suture.
No, just a second. Why bilateral superficial femoral vein? Why bilateral?
New aortic system. I need bilateral, like a Pantalon aorta.
Okay. How long is the aorta? because you do this now ending with a massive edema in both legs. Why you damage both legs? I mean, superficial femoral vein is long, so you can use for aorta for conduit, right? Aorta is very short. So you
Yes.
don't need too long, right? So you don't need too long. One long is enough. You can cut it and use it both for aortoiliac and iliac, you know, aortoiliac bypass, right?
Okay.
So no,
I
so
use
do just one leg, okay?
one leg, then aorta uniiliac, then fem bypass.
No, yeah, correct. No. Let's
How
go
about-
step by step. Let's not Nash. Let's say talk about this procedure, how you do it. So talk me about incision. Then incision. Where you do the incision, medial or lateral?
medial.
Medial, okay. And you expose. Tell me what you expose, what you ligate, because I want to know what you're taking off. Where you ligate, where you cut from where to where.
Okay.
You know?
From superficial femoral below the profound and popliteal up to popliteal vein.
Okay, and up from where? You take the common femoral vein and profunda, or below or
Below,
after? Where you take it?
Below profunda.
Below profunda. Why?
Because I need outflow.
Correct. You need outflow. So you need the profunda to be outflow because you take a superficial femoral vein. So profunda is your outflow. So you cut from the origin of the superficial femoral vein all the way to popliteal. And of course, you ligate all the branches. Okay.
Yeah.
So you took it out, and then what you do next?
I will do first from proximal anastomosis. Then I don't understand
Okay.
the aorta uniiliac or
Yes. So you cut it. You do aorta iliac, and then second piece you do iliac to the graft. You see my point?
okay, understood.
Like aorta iliac, and second one you do bypass from the other iliac to this graft. You know?
Yes. Okay. Great.
So be like end to side. So end to end and end to side. You know,
okay.
from a side. Yeah.
Okay.
That's the easiest way. You don't go and create bifurcate. Not so complicated. Just do aorta iliac and then do one jump from the contralateral iliac to the graft. You know.
Okay. Great.
But what you have to be careful about what?
Sympathetic plexus left side.
No, you see, when you do FEMP,
iliac vein.
what's that?
Common iliac vein.
No. Just a second. When you do like FEMP using vein, use like Severance vein. What do you do? How you put the vein in situ or reverse it?
This new aortoiliac system, I will use. I will not use reverse. I use the normal vein, and I do valvotomy.
Okay. Or just reverse it. Why don't reverse it?
Assess margin. According to assess margin, regarding the size margin. Because if I make a reverse, the aorta maybe 18 or 24, and will not match the anastomosis size.
Okay, I mean you can go both way. I cannot say like you have to do both. Yes, as I develop the bulb, it depends how it's a mismatch or no mismatch. But like in situ or reverse Severance vein, you can go both way. But the most important to tell him that it's a valve, you have to take care of it because he did not mention anything to me about the valve. So I mean, imagine that you don't know. See, anything you don't describe it, I imagine you don't know. So you have to tell me it's a valve, then I have to do valvotomy, you know, and then you do that. You put it there. Okay, what else you do in the leg after you finish?
Fasciotomy.
Yeah, some people they do prophylaxis fasciotomy because the leg is going to swell up, right? You know, so maybe it's the best to be in the safe side to be fasciotomy. By the way, I never did this procedure. I don't know. I never did this procedure. I never used the vein for, you know, always we use, again, I mean, before we used to use rafamycin socked. Now we use bovine patch really. It's worked beautiful. But still, I mean, you have to know this technique because sometimes you don't have a graft and you are like a rural area, so you have to know this technique. All right, let's see what next. What's the next question? Okay, let's rewind and say she's too sick to undergo an open procedure. Is any temporized measurement to treat her aneurysm? She's too sick
Yes,
to go with even axillobiafran. What you do?
I do bridge endograft.
By doing what? EVAR, correct?
Yes.
What else? You do EVAR and what?
And stabilize the general condition of the patient. Then later on, I will continue the antibiotic, and I stabilize the general condition of the patient.
Right, but mycotic aneurysm, most of it there is tissue, necrotic tissue, and pus around it, right? So it's better to drain. So yeah, so most people after they put that EVAR, they do a drainage, or even some people they do. Sorry.
CD-guided drainage.
Yes, CD-guided drainage. Yes, in the sac. And some people even they put two and they irrigate the sac with antibiotics. Some people I saw they do that. They put two drain and one go in and out. So one irrigate with continuous antibiotic. This is something to do that. And most of she has to be on lifelong antibiotics. I will not call it a bridge because she's too sick. I mean, unless if she's sick now from, if he mean she's sick because of the infection, yes, I agree, like a bridge. But sometimes they are too sick because their heart too weak, whatever. So this could be sometimes different procedure for them because they cannot go surgery anyway because like heart ejection fraction 10-15% you need. You know what I mean? But if she's sick because of the infection, yes, it will be a bridge until you treat the antibiotic and then you do it. You see, the beauty of the oral exam, you can explain your point and you can discuss with that. It's not like black and white like in the written exam. So whatever you want to do, just talk to him and explain to him why you do that, and then you go from there. You know. So this is the beauty of OSCE exam, make it easier. All right. Any more questions? No, I think that's all. All right. What time is 12:21? You want to take this case again, or not? That's enough for today?
Targarism with us. I don't know.
Any question first? Any question? Right. Forget. Let's get. Any question about the previous case? About.
Yes, Professor. I have a question.
Yes, please. Yes.
I'm asking about the mycotic aneurysms. Are they indicated for intervention, whatever the size, or not all of them are for intervention?
Let me understand your question well. You told me, do we apply the size on mycotic aneurysm? No, we don't apply it. Any size need to be treated. This is your question.
Okay.
Like if patient has mycotic aneurysm, I don't want till 5.5. No, even 3 or 4 has to be treated.
Okay.
Because an infected aneurysm, it's like a pus, it's like an abscess, so need to be treated. Regarding of the size, and most of them, most of them are sacral. It's not like, not fusiform because it's a mycotic aneurysm. And sacral aneurysm, we don't go with the size. Any sacral aneurysm need to be treated because I had chance of ruptures. So we don't go with the size. No. What was the second question, or just one question?
No, just one question, sir. Thank you.
Okay, no problem. Any other question? Should be a lot of question about infection because I'm sure you're going to get an infection. I think the exam most of you can see now about infection and aortoenteric fistula. I think they love these two scenarios. So I'm sure we're going to ask about, mycotic aneurysm, what kind of bacteria, what kind of conduit, what is axillo or in situ, all this question I'm sure we're going to get in the exam. So any question about mycotic aneurysm?
Yes, Dr. Samer, I have one question.
Yes.
What the contraindication for knee operation? Any contraindication?
Of course, that's DVT. I will not do it, or previous history of DVT. I will not do it because the vein is very bad and already thrombogenic. I think this is, my contraindications. And the reason why I need to ultrasound before you forgot to mention that. Yeah, before you do the cut, you have to do ultrasound and see how's the vein. Maybe the vein is already thrombosed. You don't make a cut right away. So when you discover the procedure, you have to tell me first. I do the ultrasound, be sure the vein is good size, it's open, no, not thrombus. And then you open. But yes, I think DVT is the only indications. All right, let's do one very quick. What is that? Pain of acute onset. Oh, this is fistula. Let's go to aortoenteric fistula. I think it's more important. Yeah, let's go to this one. I think it's more important. Can somebody read this one? Guys, it's important to practice. Don't be shy. I mean, it's okay. I mean, you don't have to know everything. I mean, so
Okay.
is Georgios there? Georgios? He said he want to do it.
Yes, sir. Okay.
Okay, just go ahead.
Okay. A 78-year-old woman presents to emergency department after a large episode of hematemesis that has since resolved. She has a history of an open triple A repair 10 years ago with a tube graft. A CT angio demonstrates thickening of the third portion of the duodenum near the proximal anastomosis, distal to the renal arteries. The patient is currently hemodynamically stable.
Good. 70 years. So hematemesis. What back in your mind you think about?
So we are thinking of triple A repair completed by aorto enteric fistula.
Correct. Because she get hematemesis, double A repair, so she has a graft there, you know. Yeah, thickening of the third portion of the duodenum is a sign you see on the CAT scan. Because you don't see free. If you see free, you don't see the fistula because it'd be too late if you see fistula. So mostly we just see thickening of the third portion, which is important. Near the proximal anastomosis. So he give you all the hint that there's a fistula there. Okay. So let's go to the questions. So what do you do next? So this is the first question they ask. What do you do next?
Okay, we are going to check up the general condition of the patient, and if the patient is unstable, resuscitate the patient. We may also perform, as the patient is hemodynamically stable, we may proceed for CT angiography.
Okay.
Or,
Okay.
and may we proceed for endoscopy?
Right. You see, this is wrong. That is why, guys, I want you guys to practice because I know it. Because you cannot see this or this in the exam. You have to give what your next step. I don't want to say what you do next. I can do CAT scan, I can do MRI, I can do upper GI study, I can do PET scan. It's not an answer. This is for written exam. For exam, you want answer. What do you do? I'll do a CAT scan. No, I'll do an endoscopy. I call GI to do endoscopy. So this is the way you should answer it. The second thing, she already have a CAT scan, right? This is the question. Let me see.
Okay.
So she already had a CAT scan. So not doing CAT scan. You see, you already have a CAT scan. So be careful.
Yeah.
Read the scenario very well. So he already had a CAT scan. She saw this one. So what's your next step? So you are there, as you said. I agree. Like you get a good history. First thing you have to ask about. Do you have a history of upper GI bleeding? Maybe she has a preferred ulcer. Maybe she has something. Maybe she has hemangioma there. Maybe she has previous bleeding from somewhere else. She may have a tumor there. So first you ask her, did you have this bleeding before? Do you have any history of GI bleeding before? Do you have any pathology you're dealing with it? Maybe she's treating now for something else. So it's very important, Getting a line is good for resuscitation. I agree with that. And then what you're next? So you do that. Then what you next? What do you do next? Let's see. No history of previous or prior bleeding or constitutional symptoms. She has some unintentional weight loss and mild abdominal pain. The physical exam is always negative except for epigastric tenderness. What you worry about? We talk about aorto enteric fistula, right?
Yes.
So let's go next. So what do you do next step?
We may.
So you think she has aorto enteric fistula, and what do you do next?
We will proceed for management of the after we has checked the patient general condition and resuscitated. We are gonna go to manage the aorto enteric fistula. I think according to she is hemodynamically stable, we can do for open surgery,
You see, no,
re-exploration.
just a second. This is not accept the exam. You see, all tell me I can or you can. I'm not asking you what can. You see, in the exam, I want you guys to do what you're doing. You are in the ER, he call you. Again, in the exam, I said, guys, imagine you are, it's not like I'm asking about your knowledge. It's not a knowledge exam at all. It is what you do, real life. I call you there. You see this, you ask question, answer all this question, and they are, doctor, what do you want to do next? He's going to ask a question. And this is real life. You're in the ER. Doctor, what do you want to do now? What do you do? You don't tell him, I may do so, I may do so. No, it's not accepted. He wants to know what you do next. In real life, what you do? Let's say you're in the ER. This patient came like that. What do you do? You rush out to the OR. You do more study. You do.
I'll go to for the OR.
Okay. I mean, it's acceptable. But I tell you, you go there to the OR. You open. There's no fistula.
Okay. Maybe from
You see?
endoscopy first to ensure
Yes.
the. Okay.
Because I mean, you think it's a fistula, but we didn't confirm it yet, right? We didn't confirm it. We
Okay.
just saw some thickening. We think it's a fistula. Yes, I agree. We think fistula, but we don't not. Maybe she has like, you know, just an ulcer, the stomach should be from ulcer. So not every patient with aneurysm come with alveolar GI bleed. That means she's enteric fistula, but this is our main concern. But we have to rule out other most common reason before we claim it. It should be our last options. Like patient with aneurysm repair come with hematemesis. Oh, my first diagnosis will not be an aortic fistula. It will be a local pathology in the stomach. So first thing I'm going to ask the guy, call GI, do scope and see. If he tell me there's nothing, I cannot very think stomach is beautiful, it's fine. Or if he sometimes they can see a sign of irritation because they don't see a fistula, then this can push me to go with aortic fistula, but will not be my first diagnosis. Okay.
Okay.
Okay. So what you do next? We ask for the GI to come and scope the patient. Correct.
Okay.
All right. Let's say what next. While patient in the endoscopy suite, brisk bleeding ensure that is unstable to control. So that suddenly when he took him there, suddenly now patient dropped down, she's massive bleeding, he cannot see anything. And she became hypotensive, So what do you do next? So
I
now she
think
became
maybe proceed.
hypotensive. Yes, not maybe. No. You see, will not say maybe in the exam.
Okay.
I will do so and so. You say maybe because maybe not. So he want to say what you do next. I will do whatever I want to do, but I say I will do so and so.
I'll do insertion of a coda balloon.
Okay, so let's head to the OR first. I mean, what I'll do first, be
Yes.
sure it has an IV line, cross match, give her fluid, associate the patient, call the OR, and rush her to the OR because you cannot do coda balloon in the endoscopy suite. As I'm saying, in the exam, imagine you are in the real life, real scenario there. What are you going to do? If I'm there, I'm going to call the OR. We have an emergency. Even I'm not sure it's aortic fistula, but now she's very hypotensive, massive bleeding. I have to open the belly, even if I have to take a stomach out, because now it's not the time to do any more testing. So even if my diagnosis is not 100% aortic fistula, I may not, but she's massive bleeding. We have even stomach, I have to control it. So we have to go and explore the patient now because she's very hypotensive now and massive bleeding. And now because she's aneurysm, that will be my first diagnosis of aortic fistula. If she has no history of aneurysm, no, I will send her for radiology for embolization. So most of she's bleeding from somewhere. But because she has an aneurysm and she has thickening in the wall of the duodenum, which should give me a sign of aortic fistula. So I have like 80% suspicious, then I will go right away to the OR. But if there's no aneurysm repair before, no history of aneurysm, and patient like this massive bleeding, it's not my issue. Then she has to go to radiology. Okay. All right, so let's see what do next. Let's see so how would you like to do? So you take her to the OR and you insert intra-aortic balloon, right? For,
Yes.
Control
bleeding.
Okay. Oh, no, wait, I'll fix that. So it's still there. They went too fast. So become hypotensive, so you go put a balloon, and after that, what you do?
I'll do exploration, transperitoneal, to explore the previously repaired aortic aneurysm. and clamping the aorta using medial visceral rotation technique. And first of all, we will open the it expose the previously inserted graft and insertion of a clamp above the site of the graft.
Okay. So what do you think? You want intra-aortic balloon pump, right? I mean, intra-aortic balloon. Then you took and you open her belly to repair the fistula,
Okay.
which is very acceptable. This is the old way. We used to do it now. Now we don't do that. But it depends how your examiner, if he's an old guy or a young guy, is more updated or unupdated. Again, if he's an old guy, he can tell you, okay, it's unacceptable. You just have to open and repair it. Most now people, young people, they don't do that because patient is too sick. She already hypotensive. She already lost a lot of blood. The aortic fistula is very difficult to repair. So most people now they just put a cuff. I mean, if actually do an angiogram, if it's a place you can put a cuff to still seal it, most of the people they just put a cuff. Stop the bleeding. Stop now, stay the patient, get her better, and always then you come back when you're more control situation, patient more stable, prepare with the general surgery because this can come in the middle of the night, and then you prepare everything, then you take her later on. If it's you do an angiogram and she's not fit for cuff, then you have to then open the way you described, okay? So it's the same, like you have to read like a rupture aneurysm. So when we talk about rupture aneurysm, we said first we do a CAT scan or intraoperative angiogram to see if fit for endo. Because endo always, when you come bleeding, endo is the best. It's different from infection. This is, yes, an infection, but more problem now is the bleeding. So anytime we deal with the bleeding, endovascular is the best. When there is an infection, of course, surgery is the best. So here is both infection and bleeding, but our priority is the bleeding now because she's bleeding. So this scenario, there's no CAT scan, no time for CAT scan. So she had a CAT scan. You can look at the CAT scan, see, but you don't know where the fistula. So you do an angiogram very quick. If you see the fistula is like she has a good neck, you can put a cuff. And mostly you can put a cuff because you aorta by fem. So the graft is eroding to the third body duodenum. So the graft usually is long. And it's easy to put a cuff because you're putting cuff inside the graft. So this is not difficult. So go and put a cuff. When the bleeding stops, then that's it. Stop now, get patient to ICU, sedate her, and then later on, we can bring her back for different surgery. Okay? All right, let's go next step.
Stabilize
so you're able
and
to place sorry?
stabilize and a bridge procedure to the definitive repair.
Yeah, but not the same, not like, and not the same day.
Of course.
Maybe after a couple of days, week, whatever maybe she's coagulopathic now, she receives a lot of blood. Now we're opening her, it's very risky because she may receive like 10 units of blood because she bled a lot. You know, she has coagulopathic, no platelets. So if you can avoid opening, is the best way to do now. So now if you can put a cuff and fix it, that's it. Stop. Get that to ICU, get the fluid, get BFFB, get the platelets, if everything's fine. And maybe next day after, you look her whenever she's stable and she's off vasopressor, she's blood pressure, she's filling up, her coagulation is normal. Then I prepare her for surgery next day in the morning where everyone is, awake, everyone, ready, general surgery is ready. Because the major surgery is not easy. It's different from myocardic aneurysms, aortic fistula. It's one of the most difficult cases to deal with. Okay? So you are able to cuff below the renal and no examination seen. So what you do next, we said we take her to the ICU. We mentioned that. The patient had an echo and unclear stress test done recently, which showed mild akinesia of the left ventricle, ejection fraction 35. She has felt unwell for the last months, leading to the poor oral intake and some. She's now weight 95 and appear quite okay. So what's the question? Now we're going to do next. Okay. So she has ejection fraction 35. Okay.
Okay.
So she has been unwell for the last few months because she's forming the fistula. So now bleeding stop. Okay. So now, like, we are dealing now with infected like myocardic aneurysm, because now there's no bleeding stopped, but we have a fistula, which is an infection, but ejection fraction 35. Okay, so what do you do next? What the procedure are going to do on her? Like after cap down, she's stable to go.
Okay, we will proceed for extra-anatomical bypass.
What the
Maybe
question?
axillobifemoral. I think we'll go for axillobifemoral bypass.
Okay, you don't think, you know, in the exam, you don't
Okay.
think. You say, I will do. Okay, please pick up to the way you say the words. You say, I will do
Okay.
axillobifem bypass because ejection fraction is low. We just mentioned that in the previous scenario. Ejection
Yes.
fraction is low, you do axillobifem because you want to decompress the heart, you know, when you clamp it. So you do axillobifem bypass. Okay, he may ask you describe the procedure, how you do it. I'm not going to go through that. That's for time,
Okay.
you know, just incision everything. I mean, just straightforward. You describe all the procedure, but you have to tell him after you finish, you close completely before you open the abdomen. Okay.
Okay.
So you do axillobifem, and then you open the abdomen. Okay.
Okay.
Do you do open the abdomen same day or you open after a couple of days? Let me ask you let me put my question in different scenario. Say you do axillobifem and then explore the abdomen same day, or let's do like axillobifem today, let her rest for a couple of days, and then bring her back to aortobifem. I mean, whatever, like different procedure.
Same day.
Why not give her some time to rest? Why do long? Because axillobifem is going to take 2-3 hours, and then the abdominal surgery going to take 5-6 hours. So why just let her rest till tomorrow and then do it the day after tomorrow or something like that?
The cardiac overload after axillobifem bypass.
But my question, why you have to do same day? Why not do it next day or day after? I mean, you can do it by the way, but you have to tell me why you can, why you cannot. Okay, they make it easy for you.
Okay.
You see, if you just decide to do the next day and just do the axillobifem, you're going to come next day, see the graft is clotted. You know why clotted? Because complete flow,
Because
right?
yeah.
It's no flow in the graft because the aortobifem is open. The aorta is open, iliac is open. So the graft going to compete, is close. Because no way can get flow to the graft because normal aorta and iliac are open. That's why better to do the same day. Unless if you ligate the common femoral, you know, on both sides, then this will stay open. But it's not good because when you go there to resect it and you close the stump, now both internal iliac not getting any flow because you close the common femoral on both sides, you close the aorta from above, so both internal iliac has no flow. So now you get to trouble. You see? So the reason why you have to do it the same day. Okay? Is it clear?
Yeah.
Okay. So you finish this one, you put your dressing, now you open the abdomen. Okay? So describe the procedure now, how you open the abdomen. You don't have to go through the details, but tell me what the step here different from normal, you know, aneurysm repair here, or what you do different. After you mobilize the colon, you mobilize the bowel, where do you put your clamp? Suprarenal, supraceliac, where do you put the clamp?
Above the graft.
Above the graft, like suprarenal.
Yes.
Okay. You put above the renal. What else you do next?
Excision of the graft and debridement of the necrotic tissue.
Okay. When you resect, you get to cut the seed. You have to be practical. So the bowel stuck to the graft. Okay. So
Okay.
then you cut the bowel from the graft. And suddenly you see the bowel content coming out. Right?
Okay.
And now the aorta, suprarenal aorta is already clamped, right? Or you don't clamp.
Yeah.
Do you cut the bowel first or you clamp the aorta first?
The bowel.
You cut the bowel first. So what happened if you cut the bowel first? You get some massive bleeding because the hole is still there, the fistula is still there, right? So the moment you cut the bowel, you can end with the bleeding. Correct?
Yeah, sorry, I don't
So you have to
understand it very
clamp.
well.
Okay. You have the hole between the graft and the bowel, correct? There's a fistula.
Okay. Yes.
So if you start dissect the bowel from the wall of the graft, what happened? Then this hole in the
Yeah,
graft is going to
bleeding.
open to you're bleeding, right?
Yes.
So you have to clamp the suprarenal first before you start dissect the bowel from the graft.
The graft. Yes. Okay.
Okay. So now you dissect the bowel from the graft, but you have a hole in the bowel, and you see fluid of the bowel coming out. So what do? You call general surgeon to fix it first, or you repair the aorta first?
Call general surgery
General
to
surgeon to
prevent
fix it.
leakage. Yes.
Okay, but if you to fix it, it's going to take him at least an hour, because he has to do closet and put, maybe a gastroenteric anastomosis, or do exclusion of the duodenum. So repair the duodenum is not easy. But in the meantime, your aorta is clamped. See,
But
this is
already I
very
have an
dangerous.
axillofemoral bypass.
You have an axillofemoral bypass. This is correct. And you clamp down, right? So the
Yes.
best way, because you cannot leave the aorta clamp and you walk outside, get the general surgery. So the best way in this one, you just get a suture, close the hole with anything, silk, whatever, just close it. So you don't get any more leak, push it to the side, and then finish your surgery. After that, he can come and he can fix it the way he wants. But don't get him fix the aorta where the aorta is a clamp. I don't like that, because maybe he's fixing, he can push the the aorta. Maybe also you have to be heparin, patient heparinized, and maybe after a while you have to give heparin more. So I will not, So what I usually do, I just put suture there, close the hole, any suture. I do it myself, push the valve to the side, fix whatever you have to do, and then when he finish, he come. Let him do the last. His part will be the last, All right. So you do that, and then what do? You're going to close the stump, suture it, take it out, and suture the stump, right?
The stump of the aorta.
All right. Okay. Let's see what we have next. What if the aorta is friable and falling apart when you try to close the stump? You cannot. Every time you would suture cut alone.
Reinforce it with a graft.
You can get some. The best way to get some tissue from the back, because there's always in the back there's some, like the perivertebra has a lot of like adventitia. You can take it with that, with a suture. You can use a bludgeon, to address your sutures. No, you can put a graft. You can get maybe a bovine to help you, but you need something to hold on it. So really, the best way, what I do, I use a bludgeon to hold it. But the best way also to use to mobilize some of the fascia from the back, from the vertebra. It's very stiff, and use it as a flap to close the stump. All right, so what sort of tissue? At the end of the procedure, you notice some mild drainage around the aorta. What is coming from?
From the
Lymphatic drainage,
it's
right?
lymphatic leakage from
That's it. Just lymphatic drainage. Don't answer too much question. Don't tell him where it's coming from, what type of just lymphatic drainage. Okay. So how you deal it? How you deal with that? You just put a couple of sutures,
maybe.
right? To try to suture it. Yeah.
Yes.
Okay. So you did that and ligate them, you drain them, you leave a large drain in the abdomen. On post of day 6, after starting the feeding, you notice that drain is putting a lot of milky fluid now. So now he has a milky fluid coming out. So whatever you suture didn't work. So he's got a leaking, lymphatic leak. So what you do? How you deal with the lymphatic leak? Sorry?
Protein-rich diet?
Yes, all called the medium chain triglyceride diet. That's what usually they do. Okay. But I mean, this is an old fashioned also. We don't do that anymore. Now you send to the radiology and they do embolize lymphatic. If you have a good radiologist with good experience, they go there and inject some onyx in the lymphatic system and they close it. And it's not difficult, it's easy. Just go through one lymph node in the groin, you inject some contrast so you can see the lymphatics. You can see the drainage. You can go there with the wire and go with the catheter and just put some onyx there and you seal it. But if you don't have a good technician to do it because you need experience with interventional radiology, then yes, you just put him on the medium chain triglyceride diet for a couple, for a week or so, and we will close. All right, I think we're done. What's that here? It came back positive. What your diagnosis? We said about the diagnosis of lymphatic range. Okay. Any question about aortoventricular fistula? Okay, guys, that's good. I thought I expect a lot of questions from this. Any question about today? Any about infection? We saw 3 scenarios. Myocardic aneurysm, aortoventricular fistula, and what was the first one? So any questions?
Yes, Doc.
Yes, please. Hello?
Yes. Asking if they give us a case or scenario regarding thoracic aortic infection, graft infection.
So I don't think anybody will ask about that. It's very, very rare, and the treatment is easy. Just take it. You cannot close the stump. There is nothing like abdominal. No, you have to take it out and put a homograft, whatever. I have a case where I have put a TVAR, I got infected. So you have to go and remove the whole thing and put a bovine graft or whatever, the same, like in the abdominal part. But it's easier and not. It's easier, but I mean, also you need a thoracic surgeon to be with you, cardiac surgeon, to clamp, because you have to clamp between the subclavian and the left common carotid artery. But I doubt in the exam ask about thoracic, because they don't consider this pure vascular. So I doubt we get an exam, so don't worry about it.
Okay, thank you.
Yeah.
Professor.
But anyway, if they ask you for some reason, will be open repair for thoracic. You just have to open the chest, take it out. You open the left chest, of course. You see the thoracic aorta on the left, not the right. So you go through the left chest. You clamp between left subclavian and common carotid artery. You clamp distal. Just take it out and put a homograft, just tube homograft. The only problem is that sometimes you have to do an ECMO, because if you clamp distal subclavian, it's too much pressure on the heart, so you need to decrease the pressure. And second thing, you want to be perfused. The distal aorta, you need to be perfused so you don't get renal failure. So what in this one, we will do an ECMO. We do VA ECMO through the femoral artery and vein, and then we perfuse distal aorta, and then you clamp, and then you put a homograft, or bovine graft, or rifampicin graft, whatever you want. And some people, they do open the abdomen, upper abdomen, and they brought the omentum, and they wrap it around it also. You wrap the with the omentum. So you just make small incision in the upper abdomen, get the omentum, pass it between the diaphragm, crura, and bring it up and wrap it around the graft. And then, of course, you put a drain. You're going to put chest drain anyway. You put a drain. And that's it, yeah. It's not common, but it's very complicated. I doubt at this level they're going to ask you it would be not fair to ask about how to do it. It's a bit complicated, yeah.
Okay. The other question regarding the knees operation. The steps.
Okay.
The steps of the knees operation need to be known for us. I just found a very little information about it. It's just longitudinal incision, lateral to sartorius, and
yeah, I mean, just like a steps, as I'm saying, it's really being done these days, because now bovine graft is there, but he may ask about it. I mean, they may expect it to know about it, I think. So just log and see. The only thing you have to let him know that you keep the profunda, you keep the common femoral vein, so important, and you reverse the valve, or you take the valve off. This is the only thing is important. And second thing, fasciotomy, and of course you have to wrap the legs with ACE bands after you finish, because you get out of swelling. It's the only thing you have to know about it.
The patency or the risk of amputation.
Patency is good. Patency is very good, but some people, they think they may get aneurysm because vein is cannot take a pressure as an aorta. So this is one of the disadvantages of them. They may get aneurysm in the futures, you know. The reason why most people, they do a bovine patch now as a tube because it's very thick. I can't take the pressure. As I said, I never use the vein really. And I never even saw it, but you should know about it in the exam.
Okay. Thank you, boss.
Yeah. Okay. Any other questions? Okay, great, guys. So see you next week. You take care, everyone.
Thank you, boss. Okay.
You're welcome.
Thank you, boss.
Thank you, everyone.